Compromising Anaesthesia Care. And it will be an practically oriented and it will be helpful to the practicing anesthesiologist. And we have a budding practicing anesthesiologist in our group. Over to Dr. Srinivas Kulkarni. I think, sir, you can share your screen and start your presentation, sir. Dr. Srinivas Kulkarni.
Yes, sir.
Yeah.
I'm very glad to talk with VAA Group, and I'm very excited to have access to this presentation.
Sir, can you increase your volume, sir?
After this subject, I will see the patient on table, compromising anesthesia care, whether we compromise or not. This is a very important factor. Now,
not able to hear Kulkarni.
Sir,
and go for slide share also.
Emergency call will be coming to you. Patient will be on the table, sir. Watched and standing in the OT. And you don't know what is the patient on the table. Mind like lamb or something like that. It's different type of this one. Don't think it's a it's a patient. Maybe line like heart disease. Maybe like we have like diabetes. So different things they investigations on the condition of the organs presently working the investigation is highly important. Nowadays, we have and we are all born for swing or it cannot be done for us. Both things, whatever in your work.
Sir.
That's why.
Sir.
Which type of
Howda? Okay. Okay, okay. Okay, okay. Stop it. Stop
Kulkarni, sir, I think you need.
Kulkarni will start separately afresh now. Sorry for the technical hitch. You can share the slide and you can please start live only, Dr. Kulkarni.
Yes, sir. Yes, sir. First, share the slides only. I'll talk directly. Video. Video is not good. Yes, okay. Video.
Okay, make it full screen and please do.
Okay, sir. Now maximize your screen, sir.
Slide presenting, slide show.
Slide show.
Yeah.
Coming, sir.
Thank you.
Yes.
Please go ahead.
Yes, sir. At the outset, I am going to thank Dr. Kiran Chand and the VAA Group organization. And I am very much blessed with all my teachers and all my colleagues and also dear students also. Now I am going to talk about, I will see my patient on table, whether you compromise anesthesia care or not. So when you are called and giving a case in a small nursing home or a corporate hospital or anywhere else, if it is patient is put on table and you are called, I'm not seeing this one. So the patient may be like lion on the table. That's having a lion means patient is not lion, having a heart disease or a severe hypertensive disorder, or a compromised having renal or liver failure. Such patients may be there which you are not knowing and you want to give anesthesia. It is a hell of the time for us. So there are two types of patient will come to call for you. It's already evaluated patient. Pre-anesthetic evaluation is done and optimized and shifted to OT table. Here, it is no need of worrying because already you have evaluated and considered all the comorbid diseases and investigation has been done and preparation of the patient is done, optimized and shifting on table, and you can easy to give anesthesia. Whereas patient shifted from the OPD directly to the OT table, it is hell of the time because you don't know anything about the patient. What are the organ conditions, systemic conditions, what is going to happen if you give anesthesia? That is questionable. So a cesarean section patient is kept there. You are going to paint the patient directly and giving anesthesia, and patient collapses because maybe patient may be having mitral valve disease. It has happened in one of the nursing home I give. So this is the one very important thing. If you want to give safe anesthesia management, you need to have a basement like pre-anesthesia preparation. Safe anesthesia house will be definitely a very good, and it comes longer duration. So what are the aims to do pre-anesthetic examination and to screen properly manage comorbid conditions mainly, and assess lower risk anesthesia and surgery by proper optimization. You have to lower the risk factors. If the patient is not optimized, the complications will be more. You cannot handle sometimes. You may go into severe complications and morbidity or mortality may occur. So to identify the patients who may require special anesthetic techniques or post-operative care. You may think patient is having immediate requirement of anesthesia and you want to give general anesthesia. It may not be correct. Sometimes patient may be having bronchial asthma, severe wheezing, or any other comorbid disease which are causing, if you give general anesthesia, patient may go into a severe complications which may cause death of the patient on table, which is never expected. So that's to obtain that one, we have to do a special anesthetic techniques which is required for this patient, which you are seeing there. So, and also post-operative care. So if the respiratory case is there, whether patient may require oxygen supplementation or ventilation post-operatively. So you have to assess and then you have to give anesthesia to obtain informed consent. So unless you only take informed consent, you explain the patient and take it is documented, then only it is valuable. Somebody takes and somebody documents, it is not correct. So you have to obtain informed consent, then only you can take it to the OT to avoid cancellation on the day of operation. So you directly go and see the patient, and if you say something is there, you are going to cancel the patient. So to avoid that, you have to do a pre-anesthetic evaluation so that anesthesia OPD should be maintained. So whenever the patient comes to an surgeon for he's seeking a surgical involvement or surgery is required, so he has to refer to that patient directly to anesthesiologist. So anesthesiologist should look into all the matters, which are the comorbid disease, what is the airway management, what are the type of anesthesia is required, previous anesthesia, whatever the things are there. So these are the things to be considered in an OPD, and he has to optimize. Nowadays, COVID has taught us online PAC class clinics. So online only you can see the patient by video calling, and you can advise what are the things are there, investigations, go through, advise the patient and prepare the patient with the treatment and evaluate, re-evaluate. So Joint Commission mandates PAE for any surgical patient within 30 days before planned procedure, as well as reassessment within 48 hours. You have seen that patient 30 days back. In that period of another 27 days, anything could happen. An epilepsy patient could have got 3-4 attacks, or asthma patient could have been attacked, or blood pressure may have high increase because of stress and anxiety is going to be have a surgery. All these things may happen. So interview the patient, review medical previous surgery and medical history. That's very important for you. So appropriate physical examination is also required, and review the diagnostic data. So whatever may be diagnosis, they have done it. They have missed some things. You have to see patient properly and come to a diagnosis and assignment of the ASA physical tests, because different ASA gradings, different type of managements and mortality morbidity rates are different, and the preparation of the patient also differs. So you have to explain the patient about that also and take informed consent, which the risk factors are going to happen to you and things to be done. So formulation and discussion of anesthesia plan with the patient or responsible adult is very important. So record it. So record things, record documentation is very important. Record the name, gender, religion, cost of the patient, and complete address available, because anything happens to the patient, you have to contact our post-operative management and post-operative approaches also very important for this. What is the indication for surgery? You have to think about it. Small surgery, the unwanted surgeries are there nowadays. The patient has diagnosed appendicitis, there is no appendicitis, they want to do surgery, or there is no indication for cesarean section, they want to do cesarean sections, or so many other things also there. The presence of coexisting medical disease is most important thing, and you have to evaluate for that. Status of the patient, cardiorespiratory fitness and functional capacity. So you have to refer to some of the physicians or pulmonologist or cardiologist for further evaluation, which is required for the fitness of anesthesia. But ultimately, you are the one person who is taking a decision for whether to give anesthesia or not. And previous medications. What are the drugs patient is already taking now, which are to be continued, which are to be stopped, like warfarin. Patient was valvular replacement is there, patient on warfarin. If you take directly, there will be definitely INR is more, and bleeding will be there, heavy blood loss will be there, patient may succumb in the table. So you have to stop and start other short-acting anticoagulants. What type of anesthesia is being depends upon that. So anesthetic history, previous anesthesia records also. Patient has undergone some surgery previously and exposure to anesthesia, some complication has occurred. This may occur now also. So any allergic things and family history also important for you. So complete evaluation of the patient is a must for elective case, especially emergency as far as possible. The required time you have to evaluate and optimize the. See, recording yourself all the things, weight, blood pressure, airway examination is very important, because difficult airway, can't intubate, can't ventilate situations are definitely you are going to lose the patient if it is not available. And available resources, you have to think about available resources also. Here, if fiber optic intubation facilities are available, video laryngoscopy is available, or some Mackay braids, something like the gadgets are available or not. If it is not available, if it's a difficult airway, you cannot do it in such nursing homes or such corporate hospitals where there is difficult airway management equipment is not there. So these are the very important things which has to be considered. So you have to recommend some of the tests, that is change or cancel or postpone surgical procedures, because patient is not evaluated properly. Patient is not optimized properly. These things are not available here. Such things there, you have to cancel the patient. You have to postpone till it is done. So yesterday patient was all right. Today while bringing the patient has got heavy fever. There may be septicemia, patient may go into septicemia or some other problems may occur if you give case on table, if you take a fever case and give. So such things are there. You have to evaluate why the fever is there. What is the problem with that? So you have to change the anesthesia management in some of the cases. You have decided to give general anesthesia. Patient is developing some problems. You want to use spinal anesthesia. No, they want to change a tumor excision, whole thing I will not do. I will take only biopsy. You can give monitored anesthesia, care local infiltrations like that. So change of anesthesia management occur on table only. So these the decisions has to be taken depend upon the patient and the patient surgery, and also confirm suspected from the history and physical examination by On table, it is not possible at all. So you have to evaluate previously only. The pregnancy test is one of the another thing, which is female patient childbearing age is very important, because pregnancy management is entirely different. Pre-anesthetic evaluation and management is entirely different in these cases, and all our anesthesia techniques may cause some of the complications during anesthesia. This is the ASA grade classification, pre-anesthetic evaluation, and we have to grade it, and we have to tell the patient, and surgical people also and hospital also, he comes under this ASA grade. He has got such and such risk factors, such and such a disease is there. Even though optimized, the chances of risk and also the complications are more in these patients. That's why we have to assess and grade ASA. Then we can know about that, what is the management, or we have to take it for the case, or we have to postpone it or not. Things will come into considerations. The ASA classification has got absolute mortality of normal ASA grade, it's 0.1%, and it doubles and it goes to ASA grade 2 and becomes more, doubling 10 times like that. So 100 times also. So morbid patient with 4, 8, 4, 5 grades are it's very important things. Even though you manage with absolute, you are taking care of this patient, still there is absolute mortality is recorded. So purpose is anesthesia evaluation is several different purposes. What are those? Guide for the selection of anesthetics. So what anesthesia you want to give, what drugs you want to give, medications, pre-operative preparation you have to do it, you have to plan for the dose and everything, load the drugs and keep it ready for that. So plan patient post-operative recovery also. Only giving anesthesia is not important. You have to recover the patient and send it to post-operative ward and look after there. Pain management is one of the very important thing nowadays, given a lot of importance to pain management, post-operative pain management, intraoperative pain management. So educate the patient about the operation. He has to cooperate. Otherwise, you can't give anesthesia. In post-operative also period, you can't give any injections or something like that. So his patient may not cooperative. So self-care during recovery time, you have to tell them what has to be done. Patient care anesthesia or pain management, all these comes to determine the need of additional staff during and after surgery. So you are giving anesthesia, some complication occurs, some person you need, you expect it. Some of the things we expected. In pediatric patients, we have to need 2 anesthesiologists are recommended nowadays. So that's why you have difficult area management. Some gadgets you many people doesn't know. You need to have an assistant. So need of additional staff has to be determined by examining the patient and seeing the things what is there. Minimize the confusion causing rescheduling operations, because last minute discoveries of the patient health. So you on the table patient is shooting up 200, 300, 200, more than 200 systolic blood pressure, more than 110 diastolic blood pressure, not coming down, giving after midazolam also. So if a surgeon think that he will not take it. Even though you are ready to give anesthesia, surgeon may think that, no, I am taking risk. I don't want to do it. So such things may happen. So previous control of hypertension may stabilize the patient and we have to give anesthesia. Improve the patient safety quality by collecting data for later review and analysis. So whenever you give anesthesia, documentation and collect the data properly, and ASA has to be noted in few control trials. Different approaches of anesthesia evaluation was conducted in 2014. That further research is also needed nowadays. So continuous evaluation, continuous modification is required to give a safe mode of anesthesia and safety of the patient. So these are the things we have to consider. So present medications are some of the patient may be taking in Ayush. They are coming up nowadays. Herbal preparations, other things. There we don't know what is the interaction with our drugs. So we have to be very careful in these herbal preparations. So these are the allergic hypersensitive reactions. So some of the drugs has to be noted down. You should avoid such drugs. So these are the only to have safeguarding others. In a patient with alcohol abuse, substance abuse, drugs, taking, smoking, all these are very important things. You have to modify them and you have to send it to psychiatrist, and withdrawal symptoms may be there. Maybe patient may be drug addict and having already psychological depressions, other things are there. He may go into post-operatively into withdrawal symptoms and suicidal tendencies. So many things are there. So you have to be careful in these patients, how to use sedatives, anesthetic drugs, and what dose is required, what drug is required. So family history of anesthesia genetically determined. So you have to see whether patient family history, they have given anesthesia, any complication has occurred, any problems are done. So that's why it is very important. So in addition to that, elderly patients and pediatric patients and pregnant patients, all these, they are the special cases. So safe and efficient anesthesia practice is required to optimize the patient. Stress response that is proportional to the magnitude of injury. So anesthesia and surgery, both are stressful. Definitely they are going to cause different physiological changes are patient. So preparation to avoid these anxiety and to optimize the patient. Total operating time is also very important. Longer the duration of anesthesia, longer the complications, post-operative complications, recovery complications. So most of the intraoperative blood loss, you expect it, you have to arrange for the blood components before taking the patient. You expect what is going to happen, or at least reserve the blood and blood components are necessary in such patients. And degree of post-operative pain, some patients are very sensitive, some patients are tolerable. Depends upon that, you have to give post-operative analgesia pain management. So pre-operative evaluation and preparation for anesthesia and surgery. So this is very important thing. This article there that says that ultimate goals of pre-operative medical assessment to reduce the patient surgical and anesthetic post-operative morbidity and mortality and return him to desirable functioning. Sir,
Flying dolphin.
sir, shall I continue?
Yeah, continue, sir. Continue.
It is imperative to realize that perioperative risk and multifactorial function of the preoperative medical condition of the patient in invasiveness of the surgical procedure and type of the anesthetic administration. A history and physical examination focusing on risk factors of cardiac pulmonary complications and determination of the patient functional capacity are essential to preoperative evaluation. So this is one of the article which majority of the death occur due to the patients of ASA grade physical status than patient with ASA grade. Because when you see the patient ASA grade 1, you will not take a much care is not taken, neglected. And ASA grade 3 physical status, you take most of the care because already patient is diseased and you are optimizing the patient and you are giving proper type of technique of anesthesia. So difference, whenever the patient comes ASA grade 1 or 3 or 4, whatever may be things, at most care has to be taken, at most importance has to be given. See, if ASA grade 1 dies or go for complications, think about that. What blame you will get, what are the things going to happen. So this is very important impact on us. So a junior anesthesiologist, when first time giving surgery, first time death occurs, he says, not like that above statement given, newly passed anesthesiologist. So this is fun. Nothing prepared by me, first death in surgery. So you should not say these words. These are the words nowadays it is not required at all. So you have to prepare, you have to get trained, and supervisor, under the supervisor, you have to do it when you are not experienced. You have to take guidance of the seniors, you have to take guidance of the evidence-based. There are so many articles and so many things are available here nowadays. There is no need of doing such errors. So anesthesia make and miss judgment or an error, perhaps giving too much of drugs or giving wrong drug should be avoided. However, modern anesthesia techniques, training, monitoring equipment mean that deaths caused by anesthesia errors are very rare. Now it is in England, it is 185,000 general anesthetics of United Kingdom. India, we don't have much statistics because of our documentation, poor documentation. So we cannot say what is happening here. But still, compared to the previous, we have got less deaths and less errors. So due to our increasing population and lesser number of anesthesiologists, most of the doctors are overburdened, may give word sometimes because stressed anesthesiologist, maybe wrong labeling of the drugs, Inadvertent administration of drugs to the wrong routes. It happens because of the stress and strain, availability of the things, manpowers. You will be doing ventilation also. You will be loading drugs also. You will be thinking all the monitors and other things, surgical site also. So these are errors going to happen. You have to be vigilant in these things. So stress anesthesia is more liable to making more fatal errors. May be subjected to greater psychological stress if intraoperative death occurs. Definitely, it is a detrimental. So hypersensitivity reaction, inhalation agents like muscle relaxants and cardiac dysarrhythmias, arrests are common when you have to optimize the patient and still you give anesthesia. These are the things, according to the incident rate, it may happen. But if you don't know the patient and start giving anesthesia, these are the common things which are going to cause patient mortality and morbidity. So various humans such as laryngoscopic failure, inadvertent giving hypoxic mixture, malfunction of the apparatus, kinked pipes, so vagal stimulation and causing other complications. So these are the small things which are very important to be considered. So if you are not able to do laryngoscopy, you need other gadgets, other mode of intubation and correction, or you can have an experienced person like that. So these are the very important things we have to be considered before giving anesthesia and plan and give anesthesia. So these are the mnemonics I was taken for some of the Indian Journal of Anesthesia production A2, B2, C2, D2 and E2, F2, G2. So A, B, C, D, E, F, G. So affirmative history has to be taken. Airway examination is very important. Blood hemoglobin, blood loss estimation and blood availability is very important. We have to see the breathing, whether it is lungs are normal or not, and his lung functions are very good. So comorbidities like diabetes, hypertension, etc. And clinical examination, whether you are able to give what type of anesthesia is compatible or not. Drugs being used by the patient and which are to be continued, which are to be avoided. Details of previous anesthesia and surgeries and which are helpful for you to avoid those complications which are occurred previously. Evaluate investigations which are required only. If you do all the investigation, nowadays they blame you, you are giving all types of investigation, not coming to conclusion. Only the end point is take up the surgery and fluid tests, fasting, give physical status and get the consent. All these are mnemonics which can be remembered very easily and can be practiced. So lab investigation are very important things. Only whichever are required, you have to think and do it. They're cost effective and time taking and also invasive things are. So risk of ASA classification in emergency, it is high, whereas in elective it is comparatively highly less. So specific correlation of ASA scores with operating times, hospital length stay, post-operative infection states, overall morbidity, mortality rates following gastrointestinal, cardiac, genitourinary surgery has been extensively studied. So still we need to study more and ASA grade 3 predictor greater blood loss, so that transfusion may be required, transfusion complications are to be noted and has to be corrected. So ASA grade 3 is more predictive of post-operative delirium status also. So you have to consider all these and give anesthesia. So pre-operative testing before non-cardiac surgery guidelines are also there. Pre-operative for non-disease surgeries. This is the risk factors are, they have made a lot of things as mortality rate according to the cardiac risk, high risk patients more than 5%, intermediate 1 to 5%, low risk 1%. So many things are being listed. What surgeries, what are going to cause non-cardiac surgery. This is a cardiac index. Already it will be noticed by everyone. I think it is the one which can be considered very nicely, and you can calculate the index which is required for cardiac anesthesia. Expected cardiac risk has to be assessed and told and given. So coming to the summary, the anesthesiologist should prepare the patient preoperatively, as there should not be a situation that could cause morbidity and mortality to the patient undergoing anesthesia procedure. More the preparation, less the risk. The anesthesiologist should not make an exception even during emergency also. He should have whatever the time is available, he should prepare for that. In order to save the skin of anesthesiologist, and also everyone must document the pre-anesthetic evaluation findings and anesthetic findings also, and post-operative care. All the documentation is very important. So no chance of giving anesthesia on table, compromising everyone's life. Thank you. Thank you one and all.
Thank you, Kulkarni sir, for your comprehensive presentation. Before we go into discussion, I welcome Dr. Nagalakshmi Madam, who is online. Madam, can you come up, please? Nagalakshmi Madam.
Hello.
Good evening, madam.
Yeah, Madam. Yeah. Good evening, Madam.
Good evening to everyone.
Madam.
So I just wanted to hear what the patient is on table means, whether it is emergency or elective case is most important. Nowadays, trauma patients will be just dragged into the OT. And then children with foreign body also will be directly from casualty, they can bring it. And elective case on the table, whether they have done a pre-anesthetic checkup previously or the diagnosis and the case posted for which type of surgery, whether it is a major surgical procedure or a minor procedure. All these things counts when the patient is on the table. There are so many things already Dr. Srinivas has quoted. These are few points I would like to add. Thank you, Bala.
Welcome, madam.
Thank you, Madam. I think Srinivas Kulkarni sir is ready to answer a few questions. Anybody has questions, we can shoot.
Shoot.
So, Gurudat sir.
All my teachers.
Yeah, it was a very nice presentation, Dr. Srinivas Kulkarni.
Sir, I used your figures, sir.
Yeah,
I used
really.
your figures, sir.
Pardon?
I used your figures, sir.
Yeah, I know many of the slides were, it was looking very familiar to me. Thank you for using. There was absolutely no problem. So, but it was a very nice presentation. I really enjoyed Kulkarni. But, you know, so much of emphasis we keep giving for pre-anesthetic evaluation, you know, it's not at all, you know, less at all. So the students now, when they are there, the postgraduate students, they should know the importance of this pre-anesthetic evaluation, because it is actually the foundation on which the whole of the building of, you know, the anesthetic management, including the post-operative care, that stands. You know, many of the complications can occur if we have not done a proper pre-anesthetic evaluation. I still remember my days in Ballari. So many times I used to be called for an emergency cesarean section. You know, the patient will be already in the lateral position and painted for giving spinal, and we had to go and then give a spinal. So because, you know, it was such an emergency many times. But even then, what I used to do is, first I used to check my anesthesia machine at least 2-3 minutes, see whether oxygen is there or not. Then, you know, the drugs are loaded or not, like atropine and mephedrine, very important. And put my stethoscope at least over the patient's, you know, the chest, and also look at her airway. So these are the minimum things one can do in that situation. But whatever it may be, like you have written that on examination on table, it is so important many times. So whatever the pre-anesthetic evaluation you have done even before, no changes could have occurred in between. So it's very important to again reassess the patient on table. So yesterday we had a case. He was a 20-year-old boy, had a polytrauma about 20 days back. He had already undergone a surgery for his spine. So when he was placed on the table, suddenly we noticed, you know, monomorphic VT. So, you know, actually the consultant anesthesiologist, you know, recognized it, and then she called me. So when I went there, actually he had a central venous cannulation also there, and they tried to, you know, withdraw it a little bit because they were thinking that that may be the cause. But when I actually gave 1 milligram midazolam, so it slightly started becoming drowsy, and, you know, sinus rhythm started. So, you know, anxiety can also play a lot. So pre-medication you are talking about, so important. Probably the proper pre-medication had not been done. So many of the diseases we have diagnosed on table also. So pre-anesthetic evaluation is so important. So thank you very much for the nice presentation. I have no questions as such.
Sir, pardon, sir.
No, I said I have no questions. Nice presentation.
Thank you, sir. Thank you, sir. Sir, I forgot about the pre-medication also, telling that one that you have told, sir. It's very important thing. So on table, you cannot give pre-medications. Before only it should be given. So I forgot to tell that.
But Srinivas Kulkarni sir, now what happened is with the corporate coming, they don't want anybody to get pain. When we were learning, it was half an hour before 45 give IM pre-medication, morphine, phenergan or pethidine and all. Now people don't want even a prick. They say that don't give in all. I think corporate they're giving everything IV. My professor was telling that no IV, but IM patients should come sedated, quiet to the OT. I practice that, but now it has changed. That's what people say. I don't know that. Is it true? Because
Yes,
people
sir.
have IV
Yes,
in many corporates. They don't want even a single injection.
Yes, sir. Yes,
Like
sir. Yes, sir. It is true, sir. No pricks before taking to anesthesia, but pre-anesthetic IV line is a must. You have a lifeline. That is where, like we call it lifeline. So lifeline is there. You can give all the medications. That's a very important thing. So oral drugs also can be given, sir. No problem. Only IM pricks are to be avoided. It's a very painful and haphazard absorption. That's unpredictable absorption. So that's why it is not recommended nowadays. Anything more?
So, sir.
We have Dr. Namazi, one of the senior members.
Hello.
Namazi is there, one of our senior members from Maharashtra.
Yeah.
Dr. Rajesh is there.
Yes, sir. Good evening.
Yeah, hello, Rajesh. Good evening.
Good evening, sir. It's an excellent talk by Dr. Srinivas Kulkarni. I really enjoyed it, but no questions as such, but a couple of comments. Nowadays, ISA, both ISA and the Indian Journal of Anesthesia is working on lines of emphasizing the point of preoperative evaluation, preoperative optimal investigations, and how to prepare a patient optimally before anesthesia. I think that's a good message for the students also. And in very, very dire circumstances, unless in a dire circumstances, we should not go for on-table evaluation. At least we should evaluate the patient before taking up the patient to the OT.
Yeah, it should be an exception rather than a rule.
Yes, sir.
Yeah.
No, many times what happens is, the pre-anesthetic evaluation would have been done by somebody else.
Yeah.
And you will be the anesthesiologist who is going to anesthetize the patient. So then on-table, assessment is also required. Other than whatever that anesthetic evaluation has already been done before. So it is again better we spend some time to reassess the patient and then only take up the anesthesia part.
Yes, sir. I have mentioned it. Whenever any other person is assessed, he may not be missing some of the things, or he may be over enthusiastically written some things. So you have to reassess and analyze, then only you can give anesthesia. That is mandatory.
Yeah, because many of the times in
all medical colleges, the pre-anesthetic evaluation is done by somebody, and the anesthesia will be given by other fellows. So that's why
postgraduates will be doing the pre-anesthetic evaluation. So it is better as consultants we do assess on table as the patient is shifted, or even the pre-anesthetic evaluation, pre-anesthetic holding area. Yes, so it is always better to evaluate the patient, at least take 5-10 minutes, evaluate the patient again. So, the PGs might have missed many things. So then only, and it has, many times we have had these kind of things when PGs have missed, and then we find it on table or in the pre-op holding area. And so suitable modifications for our technique we have to do so that, the patient can be safe. It's all because of the safety of the patient, finally.
Thank you, sir.
No,
And
one more thing is, when you are grading ASA, simply you write grade 3, grade 4 like that. You should give the reason why you are taking that case.
That's why I mentioned, madam. That's why I mentioned what are the
you have to record in the case sheet that why you are putting that case as a grade 3 What is the reason?
That's mandatory, madam. We have to tell all these comorbid diseases. With that, we are come to conclusion that ASA grade 3, like that.
Like this, and so I am taking the case as an ASA grade 3, like that it should be
Yes, madam. Yes,
written
madam.
in the PAE note.
Yes, madam. Thank you, madam.
Sir, sir.
It was a good presentation by Dr. Kulkarni. I think he has done a lot of homework before presenting. It's really nice. And I just tried to add upon what Dr. Gurudat is telling. It's 100% it is correct. But thing is, even the beginning of my practice, I used to see what he was telling. The patients were already positioned for the spinal anesthesia also. It's not, it was not an unusual scenario. But then I call it more of a evolutionary phenomena, because that is probably last about 20 years or 30 years ago, that was the practice. Now, even the surgeons have become more cautious and more careful. Everybody is recognizing the importance of the pre-anesthetic evaluation, optimization, and the role played by the anesthesiologist. So therefore, all the previous presentation, including Dr. Rajesh, whoever is told, it's, and Madam's point is very, very clear. Documentation is becoming very, very essential. So therefore, we have to record in an institutional practice. Yes, like Dr. Kulkarni is telling, it might be seen by multiple people, different people. But pre-anesthetic evaluation, according to me, a simple look at the patient is going to give a lot of information. Say, obese patient, I'm little prepared. Thin patients, majority of the times, things go smooth. Say, like a spinal may be difficult, or an epidural may be difficult. And look at the patient, an anxious patient, more likely to trouble us intraoperatively as well as postoperatively, because say like what VT or whatever he was expressing, see, these are more common. Vasovagal faintings also I have seen. So anxious patients, such of the things we can see during the preoperative evaluation. This is one. Second most important thing is the what profession they do. What is the job they do? Whether he's a manual laborer or a sedentary office worker or something like that. Manual laborer, if simply you say, they have got an excellent, good reserve. I don't say the best reserve, but definitely they have got a better reserve when compared to sedentary workers. So some small little tips
And everyone.
possibly will help us to prepare ourselves, because the more I'm prepared, least number of complications we see. And when we are not prepared, even the smallest complication will be a big nuisance, big headache for us. So the importance of pre-anesthetic evaluation cannot be overemphasized beyond this point. It is absolutely necessary, both from a practice point as well as from a legal point also. So I must congratulate not only Dr. Kulkarni, but also the organizers of the event for choosing this important topic, so that our younger generation will take it up more aggressively and make it probably, I should say, mandatory also. Regarding the teleconsultations, yes, I do not know how far it will be successful, because unless until our patients are also equally educated what to convey and how to convey, I do not know. Of course, I don't have much experience in that. Some of the institutions are following it. Probably that may be in the future. But whatever you do, it is absolutely essential that a good PA is required. It has to be in thorough examination and the history taking, and then subsequently documentation. Of course, a review, pre-operative review, just before going to the table. So these are the things what he has nicely summarized. Dr. Kulkarni, congratulations, you have done an excellent job. Thank you very much, Dr. Kiran, Dr. Bhaskar.
Thank you, sir. Thank you, sir. Thank you.
Thank you, sir. Thank you so nice, sir. Thank you. I thank all my teachers, organizers.
No, we will wait for any other input, Kulkarni. You may not be finished. Dr. Namazi is there, one of our senior members. I think, sir, Dr. Namazi, are able to hear us? He is from Maharashtra.
Appreciations.
Many of us know. And in fact, Dr. Lalit Raigar was there. He is also from Madhya Pradesh, but I think he just left. I was trying to get him online. Definitely nice presentation, and it should be addressed to both the youngsters and the seniors also. Youngsters, because it's part of their job and duty. there's always a tendency for some complacency, especially in private practice when somebody is jumping from one OT to another OT. And if you go back to the data with respect to the errors and the mishaps in anesthesia, monitoring has improved, the devices have improved, everything has improved, but the human error, we have not been able to get down. So it stays at a particular percentage, and this is a reminder and very good topic. Actually, Dr. Srinivas Kulkarni himself picked this topic. We are very happy with the title and the whole discussion. Thank you, Dr. Kulkarni, and very happy to have Nagalakshmi Madam for our program and sharing her wisdom, and especially the experience is very important from senior members. Thank you, Madam, for joining. And Prashant, you have got any input? Dr. Prashant Sajjan.
Sir, good evening, sir.
Yeah, good evening, Prashant.
Sir, it was very nice presentation. Even we had a similar case, sir. Like on table also we were experienced some of the junior anesthesiologists. They are seeing all VT, VF and all those things. SVT, all those things we are encountering. Especially the junior most just now finished, like what sir said. The same thing is we are also experiencing.
That's the thing. But when sir told, Buddha sir told, these things could be detected if you correct the ECG monitor first of all.
Yes, sir. Yes, sir.
So these are some of the lapses. I don't say deliberate. It's because of whether they are busy or they have become very complacent. Two things. Because there will be an option for the ECG in the monitor, but some of our either youngsters or seniors, they are not. They don't do that. They don't connect the ECG first of all.
Yes.
It helps a lot, especially at one end in the pediatric patients, because in pediatric patients, when the child moves, there is a tendency for the finger probe to get discharged. So at least you will have a heart rate which has the tone of the heart rate has got very good importance in pediatric patients. So we should make a habit of definitely connecting the ECG monitor on the table. And secondly, irrespective of the age also, but please connect the ECG monitor. So that gives us a lot of information, which we don't get by the pulse oximetry. So definitely we can get the diagnosis of the dangerous arrhythmias.
Our old method of precardial stethoscope itself is a very diagnostic
pediatric patient.
That we have forgotten. Everybody has forgotten it.
Forgotten.
So these two we usually encounter while imaging, sir. Especially the ED people call us. They want to take some patient for imaging, MRI and all those things. And these people, they don't visit the patient and directly they will tell that I'll come to the MRI room or CT room. And all of a sudden they connect and they observe all those things. This is what we have encountered.
Yeah. That's Any other opinion? I think Kiran?
I think if there are no further questions.
Our senior colleague, Dr. Margi, he has joined, I think.
Hi, Margi.
Namaskara, Margi.
He is my classmate, sir.
Namaskara, Margi. Unmute ಮಾಡ್ಕೊಳ್ಳಿ.
Unmute yourself.
Unmute ಮಾಡ್ಕೊಳ್ಳಿ.
Hi.
ನಮಸ್ಕಾರ ಹೇಳಿ.
ನಮಸ್ಕಾರ ಸರ್. ನಮಸ್ಕಾರ ಸರ್.
Any inputs from your side?
It's a very nice presentation, sir. Very nice presentation.
Thank you.
And very nice topic to be selected. Very nice topic it was.
Okay, thank you.
Okay, sir.
Thank you.
Srinivas, sir.
Hi.
Hi.
I'm Srinivas, sir. Another comment
later.
No, I think Dr. Venkatagiri, our president, is conducting an online program next month. He can share the details and we will also be part of that online.
Yes, sir.
Dr. Giri?
Yeah. Namaskar, sir.
Namaskar.
That is ISA Kerala State midterm CME and PG quest we are doing that like PGXL. We have kept half day for topics like this with mutual talking with Bala Bhaskar, we selected some topics, clinically oriented, particularly case discussion, case scenario giving that. We wanted more of than a theoretical one is that. Another one is some talks on work-life balance, then financial aspects, saving and this thing. This what we have done. Practitioners, some topics coming immediately after course, how to do the practice and what are the difficulties. The non-technical assistant, many places if you go to private practice, there may not be a qualified. So these are the topics which we have selected. And I will share to everybody the topics and other things by tomorrow. I will send to all the groups in and my personal groups and others. I will send it tomorrow. I wish all of you attend that. I will send the link and all for everyone. So it will be interesting. Dr. Harsur is also faculty. Bala Bhaskar, Gurudat are all there in that. So I wish that more and more people join. First day is a PG session only. Second day is for practitioners, and the PGs also can join. That's more. Afternoon session is for the private practitioners. We kept like that.
Dr. Namasi has raised his hand. Sir, you are there, sir?
I'm very much happy to see you. Very nice presentation by Dr. Kulkarni.
Thank you, sir.
Only thing I remember those days when I started my anesthesia career with open drafts, nothing, no monitor was available. When I have to keep our bodies, hands, eyes, these are on a stethoscope. We're very much sincerely monitoring the patient, which has been, I think, because of all this gadget has come down, and monitoring a little bit, I feel somewhat maybe lacking as per my as compared to those days in earlier days. But however, we improved monitoring and all the different types of the airway and all those things. We are happy, and we are much. Only thing must be to monitor. We must also have very much alert, attentive to our monitoring and all this. Okay, thank you very much, sir.
Thank you, sir. Thank you, sir. Dr. Srinivaslu.
Hello.
Srinivaslu, sir.
Yeah, please.
Yes. This is more common, I think, during our freelance anesthesia, and also when we have accepted a lot of cases on the same day. So during such time, I think many times it happens. The patient will be already on the table, as Gurudat sir and Harsur sir were telling. We have to already paint it, and they will ask us to give spinal anesthesia like that. But we have to take care to examine the patient, at least take brief history and auscultate and check the relevant investigation and do the checklist and then go ahead with the surgery. Actually, this is to save our skin rather than anything. Nice presentation, Kulkarni. Congrats.
Thank you, sir.
Nice discussion. Kiran?
Yeah. So if we don't have any further input, I think I thank all the members, particularly our president, Dr. Venkatagiri, to have taken his time and be present with us and for his inputs. I also thank Dr. Harsur sir and Dr. Gurudat sir for their inputs and their advice. I also thank Dr. Rajesh Anji, Dr. Ismail Namazi, Dr. Prashant, who have given their input. We'll be back with a new topic in the next month.